and we'll take it from there. Welcome, everyone. Hand over to Firas.
Okay, thank you, Athar. So this, we will run it as a Viva style question and answer session between me as the examiner, fortunately. I'm lucky, the lucky one, and Athar will be the candidate, the unlucky candidate. We have collected the most common questions that could be asked about bone cement, about 9 questions. It's very unlikely you will be asked anything out of these. We kept it as, try to stay as concise and brief as possible in our answer, and just to give you a framework to build your answer on. This is the topic. Now, Athar, can you please tell me what is bone cement?
Bone cement, or polymethyl methacrylate, is a composite material, and it can be described based on its mechanical properties and biomechanical or chemical properties. The mechanical properties includes poor tensile strength, moderate shear strength, and strongest in compression. It is brittle, it is notch sensitive, and a young modulus between cortical and cancellous bone. It has got viscoelastic properties, which makes it undergo creep, stress relaxation, and exhibit hysteresis.
Thank you. So here clearly, Athar, there's no, I just want to emphasize, there's no clear definition anywhere about what is bone cement. And you'll have to make up a definition in your preparation. You have to come up with a ready-made answer that Athar has given very nicely. What is bone cement? This is the definition. It's very simple definition, really. It doesn't tell much. So you can't just say it's a composite synthetic material that's used in trauma and orthopedics and stop there. You'll have to add something to it to promote the examiner, to direct the examiner where, that you know what cement is and where do you want to proceed. So after the simple definition, which you could see there, bone cement is a composite synthetic material that's used in trauma and orthopedics. As simple as that. Its main component is PMMA. So you're showing the examiner that you know there are various components. You may be inviting them to ask you what are the components or different components. So that's the main component. It has viscoelastic properties. And also here you're showing, you know, you understand and you have a vision about the biomechanical properties of this material. And it functions as a grout and filler. So you very quickly, within 3-4 sentences, you showed the examiner, you know what bone cement is, functions, properties, and components, main components. And this now, you won't score any points yet, but this will drive the examiner now into moving into the next question. They know they are facing candidates who quickly, within a few seconds, give very good definition. Move on now, Athar, to the next question. Thank you for the good definition. Now, can you tell me, what are the properties of bone cement, please?
So the properties, as I explained, it has got the mechanical properties where it is poor tensile strength, moderate shear strength, it's strong in compression, it is brittle, it is not sensitive, it has got young modulus between cortical and cancellous bone, it undergo creep, stress relaxation, and exhibit hysteresis, which are viscoelastic properties.
Excellent. Excellent answer. That's you told everything about the mechanics of cement. So again, the examiner can take the question into any direction, but we're trying to cover all possibilities. So we've started with the biomechanical properties of bone cement. It's a viscoelastic material. And here it could go into the viscoelastic properties. So, but please straight away tell the examiner, you know what viscoelastic material is. It exhibits 3 characteristics: creep, stress relaxation, and hysteresis. And then the examiner might then want, if they want to, but I mean, this question is about cement, but they want to take you in that direction, drawing curves and stuff like this. other properties, it's other mechanical properties. It has very high compressive strength, but very poor tensile and shear strength. In the stress strain curve, it has low stiffness, so it has low modulus of elasticity. In the first component of the curve, and the second component, it's brittle, so it does not deform much, and it breaks straight away. So viscoelastic material, compressive strength, low tensile shear strength, brittle, and low stiffness. These are the main biomechanical properties of cement. Brilliant. So we'll move on next question. Athar, can you tell me what are the clinical indications to use cement?
So, like every question, we'll start big. And the cement can be used as a grout or a space filler. It can be used as for eradication of infection, and it can be used to fill void in bone, whether it's osteoporosis, whether it's benign malignancy, or whether it's a crush fracture.
Okay, thank you. So again, classification. For every answer, we have a clear definition what cement is. We have clear bullet points of the mechanical properties and the functions. Now we have two main functions. You mention them to the examiner straight away. It's used to aid fixation and as a void filler. And then you start talking more about it. I'm sure you can fill these lines. So how it aids fixation, very important. Make it clear. It's a grout, it's a filler. It's not a glue or adhesive. It's a grout. It fills the gap between the prosthesis and the bone. And it provides mechanical interlocking when it hardens and it sets. That's how it aids fixation. Grout, not adhesive. So that's the first function. Second function is it's a void filler, and that can have many indications. It could be used for cystic bony lesions to strengthen the bony defect. It can be used as a void filler to treat osteoporotic vertebral fractures. It can be used if there are bone deficiencies in cases of revision hip replacements. How it works is basically transfers the load from the prosthesis to the bone and acts as stress distributor. Another indication is it could be used for treat infection as a void filler if there is an infected cavity in the bone or surrounding soft tissues, cement beads. These are the main indications for usage of cement aid fixation and void filler to achieve various functions as we outlined here. Okay, Athar, we move on to the questions, commonly asked questions. What are the main ingredients of cement, please?
So there are two main ingredients. Again, I'm starting big and going small. Liquid monomer and powdered polymer. Liquid monomer that is being supplied in a glass vial contains methyl methacrylate monomer, inhibitor stabilizer called hydroquinone, and an activator N-dimethyl p-toluidine. So liquid has got monomer, inhibitor or stabilizer, and activator. The next big heading is powdered polymer that contains polymer granules of PMMA, inhibitor, initiator, benzyl peroxide, and a radio-opaque material, zirconium oxide or barium sulfate.
Thank you, Athar. So again, classification to start with, it's made of two things, as Athar said, powder and liquid. Okay, show the examiner that you've seen cement before, you've used it. It might look silly, but it's very important that you classify it like that. It's two components, powder and liquid, and then you start going into these individually. So the powder, the way to remember is powder P for P. So powder is contains the polymer. So powder is methyl methacrylate, contains the methyl methacrylate polymer. The powder also contains the radio opacifier, which can be barium sulfate or zirconium. The powder contains the initiator of the polymerization, like benzoyl peroxide. You could add on here to the examiner that the polymerization produces exothermic reaction, raises the temperature up to 50 degrees. In addition, sometimes, not always, antibiotic can be added to the powder, most commonly aminoglycosides. And also there is a dye that's be added to color it, to make it more visible. That dye could be chlorophyll in Palacos cement or ethanol and ascorbic acid in CMW cement. So this is the components of the powder. These are most common components. And my advice is whatever cement you use, next time in theater, just out of the box, take the instruction leaflet that tells you the ingredients and read it. So you know when you go for the exam, the components of the cement you use. The second component is liquid. The liquid is colorless, it's packaged in ampoules normally, and it has the monomer. In addition to the monomer, it contains the accelerator and the inhibitor. So the powder has the initiator, the liquid has the accelerator. Liquid is colorless, is packaged in ampoules, and it contains the methyl methacrylate monomer, and also the accelerator and inhibitor. So the powder starts the reaction with the initiator, and then the liquid takes over with the accelerator and the inhibitor. Okay, and obviously this has proper scientific names, but I think that will suffice if you say initiator, which is, I know it is benzoyl peroxide, and there is also accelerator and inhibitor. Okay, guys. So these are main components of cement. You know, it's very useful for your MCQ. You know, part one, also for the Viva. You know, this could come. Okay, our candidate. Can you answered very well about the components of cement. Can you now tell us how does the chemical reaction occurs between this polymer and the monomer, and what's the clinical significance of that?
So the chemical reaction that occurs between the monomer and the polymer is called a polymerization process. The reaction itself is exothermic and it's highly energy inefficient. So 90% of the energy get absorbed through heat. In the polymerization process, the carbon-to-carbon double bonds are broken down and a new carbon single bond is formed to give long-chain polymer that are largely linear and relatively free of cross-linking. The reason of this explanation is when it's linear and it's free of cross-linking, it has got a very poor tensile strength, which is one of the properties of the cement. And as you use tensile forces in the cement, it breaks because of no cross-linking. And hence this explanation is there, and the question is there.
Excellent. Thank you. I thought that's very good. And I have to admit, it's not easy concept to understand, and you explained it very well. So in summary, this process, I mean, you'll be doing well to be, I think, in my opinion, to be asked this question.
Yes, so the questions now started is, you know, after passing,
yeah,
and now you're heading towards good marks.
Yeah, absolutely. So the process is called polymerization. The reaction is exothermic and therefore will produce heat. It's energy inefficient reaction, And as Athar said, their carbon-to-carbon double bonds are broken into single bonds and forms long linear polymers. And unfortunately, these polymers are don't have the cross-linking property, and that's why cement is weak in shear and tensile, under shear and tensile forces, because of the lack of cross-linking between the carbon chains. Excellent. So, Athar, you said that one of the powder components, sometimes antibiotics is added. Can you add any antibiotic, or is there specific prerequisites for the antibiotics to be added to cement?
So there are a few very important prerequisites for the antibiotics. The most important one, it has to be heat stable, as the polymerization process initiate a thermal energy, and if the antibiotics is heat labile, its effect will be cancelled by heating. So it has to be heat stable. It has to be a polymicrobial, like it covers all varieties of gram-positive, gram-negative bacteria. It has to have a long effective period where it can last longer within the tissue, and it does not create too much porosities within the mixture, so that it doesn't decrease the biomechanical properties of the cement. So these are the 4 properties I'm aware of.
Thank you. So again, just to recap, main 4 properties of antibiotics added to cement should be thermally stable. It should have wide spectrum of action. It has a long elution time of, typically gentamicin is 6 to 8 weeks. And it should not compromise or have less effect on the mechanical stability of the cement. You can't add any antibiotics because they could affect the mechanical properties. So these are the main 4, and those also could be tested on both part 1 and part 2 of the exam. Great. So, Athar, you told us about the components, various components and properties of cement. So now, what happens when you mix all these components in clinical practice? What are the stages of how do they say together?
So within the clinical practice, this is called a currying process, as if you're making a yogurt. There is a dough time, which is the time when you mix the powder to the monomer and you are mixing it. Then there is a setting time until the surface temperature is half of the maximum. And then there is a working time on which you can actually put the cement in. This is the difference between the dough time and the setting time. And then there is a working time, which is the last time up. And I think I'm not aware of it. So this is one question I didn't know.
You're doing okay so far. So again, the phases of cement setting, there's some controversy about it, a little bit of controversy, and that doesn't matter. Just find a system that works for you. This is a system that I use, that I prepared for my exam, and I think this is clinically more practical. I don't think examiners will argue much with this. So there are mainly 4 stages or 4 phases. First phase is the mixing phase, is the first few seconds, about 30 to 50 seconds. Vacuum is used obviously in advanced cementing techniques now to reduce the pores and therefore increase the tensile strength of cement. So first stage is mixing stage. Second stage is the doughy phase, and that starts from the beginning of mixing. So that includes the mixing time, okay? From the beginning of mixing until the cement becomes unsticky to the fingers. That's the clinical implication of it. And that varies obviously between cement and cement. And that's during this phase is where mainly the viscosity of cement carries some clinical significance. So between low to medium to high viscosity cement, it all depends on how it acts during the doughy phase. The third phase is the working phase, and this working phase also includes the mixing. The working phase starts after the doughy phase, and that's the phase when you actually putting your implant on, whether it's a hip replacement, knee replacement, etc. So this working phase or the implantation phase. So it's from the end of the doughy phase to the so it starts from the end of the doughy phase, and it's normally about 6 to 7, 8 minutes depending on the cement you use. So you need to know that each phase for the type of cement you use, and there are many factors that affect the duration of these phases. Okay. The last phase is the hardening, and that starts from the end of the working phase and could last up to 24 hours. It's very important, and it is one of the principles of Exeter stem, how it subsides into its position in the bone. So it could take 24 hours and even more to reach its ultimate strength. I have this diagram I've taken from Joydeep Fadne's notes. I hope you guys can see it. And it is very good diagram reminder of the various phases of cement setting. It will be there for you to see, but I think this is clinically most practical one that I could find. So again, 4 phases of cement setting. Okay, and just to remind you, that's the only constant time is the mixing time. That's controlled by your scrub nails. But the rest of them, they're all affected by many external factors, mainly the temperature, maybe the instrument you use to pressurize and stuff. So increased temperature and increased mixing and handling of the cement will reduce the working time. So if you have a high temperature, if you have nurses who mix by hand a lot, that will reduce your working time, and you need to be aware of that, obviously, intraoperatively. The humidity will, in contrast, lengthen the doughy time, and also you need to be aware of that. Okay, so these are the extra factors that could affect your cement setting. Okay, so Athar, is cement completely safe, or are any serious complications?
So there are various complications for cement, starting with bone cement implant syndrome, which is the most serious complication. It's rare, but it can cause hypotension, fat embolism, and it can make patient really unwell, secondary to ARDS. The other complications of the cement can include thermal necrosis, either of the bone or the soft tissue around it, chemical necrosis of the bone, third body wear, cement mental defects, and cement reaction to patients who are allergic to it. They are rare but significant complications and cause problems.
Thank you. I think generally when you're proposing treatment and they start to ask you about complications, that means you should be doing quite well. So there are various issues that can happen with cement. The most serious complication is what's so-called bone cement implantation syndrome. And there is no specific definition of this syndrome in the literature because it's poorly understood. However, it's what we know. It's a rare but life-threatening condition. It occurs around the time of implantation of the bone cement. Symptoms and signs are hypoxia, hypotension, cardiac arrhythmia, and can eventually lead to cardiac arrest. The exact cause is debatable, and please don't The most common cause is fat embolism. The cause is fat embolism, and it's thought to be due to increased intramedullary pressure. Other possible causes are air embolism, exothermic reaction, or toxic hypersensitivity or anaphylaxis to the monomer. Now, the next question examiner could ask you, and it is higher order thinking question, is how do you prevent this syndrome? And the way you approach it is, as again, classify. So what the anesthetist can do and what the surgeon and the surgical team can do. What the anesthetist can do is, anesthetist gives fluid to maintain normovolemia. Anesthetist gives high concentration of oxygen. And these are all, these steps could be taken by the anesthetist. By the surgeon, to reduce the risk of fat embolism, pulse lavage and brushing of the medullary canal of the femur to remove any fat debris that could be pressurized into the bloodstream. To reduce the risk of air embolism, it's recommended now to mix in vacuum, to put a ventilation tube inside the femur, to let any excessive air comes out, and to use a retrograde cementation method, and that's also an advanced cementing technique. So retrograde cementing with a gun. And these measurements will all reduce the risk of air embolism. And now I'm talking about it, just remembered also there is another factor related to hydrogen peroxide usage and the concentration of hydrogen peroxide. Hydrogen peroxide is used as a hemostatic agent to reduce bone bleeding, and that will allow better interdigitation of cement into the bone. The risk is that it can produce air embolism, and the MHRA guidance that it should be diluted. Okay, we'll move on now. Again, another high scoring question. Athar, do you know of any radiographic grading system of cementing?
So yes, there is a Harris modification of Barak's grading system. It is graded from A to D. A is complete whiteout. B is nearly complete with some cortical defect. C is when there is 50 to 99% radiolucencies, or less than 50% radiolucencies, and D is gross deficiency in cement mental. For example, there is no cement distal to tip, or there is any part of the implant which is touching the bone. It can be avoided during the eras as the cement generation increases from grade 1 generation to 4th generation. So first generation was hand mixing, finger packing. Second generation was medullary plug, canal preparation, cement gun. Third generation was vacuum mixing, pulse lavage, cement pressurization, and proximal centralization, distal centralization. Fourth generation is all of the above with distal and proximal prosthesis centralization. And that gives even cement mental all around the prosthesis, which is Barak grading A.
Thank you, Athar. I have nothing to add to that. This is the classification, Barak and Harris, in front of you, as Athar said it. Cementation generation also an important topic to know about. It could be a little bit confusing sometimes, but it's good to be aware of. And it's mainly used for the femur anyway. It's not generic. So it's also a good topic to know. But this is Barak and Harris radiographic grading system, cementing techniques, A, B, C, D, from white out, no distinguishable border between the bone and the cement, to defects of less than 50%. Then B is defects more than 50% of radiolucency, and D is either 100% radiolucency around the stem, or absence of cement distal to the tip of the prosthesis. Brilliant. Now you've done so well, Athar. Now I'm intrigued to know what cement you use and why.
Okay, well, so now this is really, I'm burning my wings here. It's really higher order question. And the only thing I know is Pelcos R plus G. It is widely used. It has various studies available, both in humans and experimental, and it's the oldest cement I can use. I can think of, but I don't know this question that well. I'm sorry.
Okay, that's okay. You passed already. But like any other material you use in your practice, whether you use prosthesis, trauma implant, suturing, anything, you should have for the exam evidence-based backup of why you use it. So answers like, that's what I'm normally use, that's the only one I have in my hospital, that's what my boss use, these are all wrong answers. You should have your own thinking and background reasoning, because when you become a consultant, you have to use your own implant and materials and justify it. So the cement I use is Pelcos R and G. The reason I use it, it has a high viscosity, so therefore it has short doughy time. I don't have to wait long time for that, and it has a very good working time. That's the time I need the cement, the implantation time. It has a green, distinguishable green color, so it's easy to identify. If any leaks into the surrounding tissues are relatively easier to find. In cases of vision also, you can see it. It has, G is for gentamicin antibiotics. It is very good antibiotics added to cement. It has a consistent antibiotic release. The radio opacifier added to it is zirconium, so it could be seen on X-rays. And it is sterilized using ethylene oxide. And this method of sterilization will preserve the mechanical integrities and mechanical properties of the cement. In addition, as anything to do with implantations of joint replacement, anything like this, NJR, please. These figures are a little bit old, but the NJR data support the use of Pelcos as the best cement with reduction of revision when used for both total hip replacement and total knee replacement. So it has NJR backup. I'm also aware that Pelcos contains traces of peanut oil, and therefore has to be could be contraindicated or has to be used with caution in people who have peanut allergy. But whatever cement you use, whatever implant you use, always have an answer to it. And I feel when they ask you this one, that means you should be doing really, really well. And if you answer this question well, you'll be scoring very high. And I think these are all 9 questions we prepared, Athar, myself. We don't know that anyone been asked anything about cement out of these main points, to be honest. I think this covers what you need to know. You will pass, I think, if you know this information about cement. And again, classify, keep it simple, scientific, and just keep talking, answer the question to the examiner, and don't give them a chance to ask you any awkward questions.
Firas, I've said to him that the void is a cavity filler. So it fills a cavity, a defect in the bone. And grout is an interface between the bone and the implant. So it fixes the implant.
Yeah.
Okay.
I think that's very good.
Okay, can I can I just clarify that question about the question I brought up about the hydrogen peroxide for us? First, before I do that, Athar demonstrated to everyone very nicely. Do not answer that last question with "I use this" and then stop. And Firas very well demonstrated why you should not do it. Go to the basic science of what you're using and what you want. Talk about the ideal prosthesis, talk about the ideal cement, talk about the ideal anything. You don't have to name a company or a particular product. You just need to talk about what it is you want from the product. They want to know the science behind what you're using. Now, to go back to that hydrogen peroxide, just to make you aware, the MHRA recommendation for hydrogen peroxide is that it's off prescription for hip arthroplasty, and that it's at your discretion if you use it. The issue associated with it is that there has been a registered death associated with high dose of hydrogen peroxide use. Its use is multifactorial, correct for acids, for hemostasis, and it is for, but it's also used as a antiseptic, a mechanical antiseptic. It kills bacteria by mechanical means. It's also used as a debrider of tissue bulk, so it kills off tissue bulk. As I said, MHRA published guidance, and there's a British Hip Society letter sent out on the 26th of the 1st, 2015 in reference to that guidance. I'll send it on the Telegram group.
Thank you for clarifying. I think, yeah, just I found it. I agree with what you said exactly, Shwan. And just to add, it's the concentration. There's a British Hip Society and MHRA guidelines about it. But I think normally in clinical practice, I think the bottle comes in concentration, I think, of 6%. And the MHRA guidelines, it should be 1.5%. So don't let the nurse pour that straight away into the gallipot. They have to dilute it for you to get the concentration of 1.5%. If you exceed this, you will be breaching the MHRA guidelines, and that's obviously a serious thing. So if you talk about hydrogen peroxide, please mention it has to have 1.5% concentration.
Okay. So someone asked about Hani Elberdesi is asking that the FRCS examiner asked me what happens when the patient with cemented THR starts weight bearing. So I think the answer to that, I think he's probably trying to point you towards two types of cement prosthesis: shape closed and force closed. So shape closed design is a complex cantilever design, and it relies on friction, shear forces between the femoral stem and the surface, and it makes bone and cement one, so you can just weight bear on it and there is no subsidence. The force closed design, which is the new generation which we use now, which is the triple taper exeter polished stem, it relies on controlled subsidence of femoral stem component to cause radial compression of the cement. So it compresses the cement radially, and in return, which is resisted by the hoop stress generated within the femoral cortex. The stem is known to subside in air-filled centralizer, which leads to low shear stresses and high compressive stresses. So using the cement mechanical properties. Shwan
discussing the viscoelastic material cement and the reason why you use cement and the reason why your prosthesis is a triple taper stem design. You've described it perfectly. Well done. This is okay. So this is an interesting question. I'll answer this one straight off. How can you remove cement after implant if you accidentally drop the stem on the ground? First thing you do is get lots of cold saline and throw it into the prosthesis and pull as much cement out as you can, and then hope that you've managed to take as much as you can. Failing taking out as much cement, then you're going to revision prosthesis type techniques. But one technique you can consider if you've taken not all but some amount is a cement in cement technique. So you'll need to use a smaller prosthesis, smaller stem, not smaller head, smaller stem. And you can then wait for the original cement you put into cement and then use a smaller prosthesis. The problem with doing that then is you've got a massive cement mantle, and that can cause the kinematics of your your hip replacement to change, and a higher risk of cement fracture and loosening of your prosthesis. The other option is switch to revision mode. Okay, what's the difference between cements of different viscosity?
So I know this question because I use cement of different viscosity. So a high viscosity cement is required as a grout, which is between implant and bone. A low viscosity cement is required as a space filler, because sometimes when you're doing osteoporotic crush fracture, vertebroplasties and all the rest, you're squeezing cement through small tubes, and a high viscosity cement will not flow through those small tubes. It needs a low viscosity cement. Again, if you're doing a cement to cement revision, like Sean described, and you have used a high viscosity cement initially, you don't want to use another high viscosity cement straight on that will fill the whole gap. So you want something that allows you time to fill the gap, and it can go into small areas of defect, which cannot be filled with a high viscosity one. So low viscosity can be used. Again, these are plenty of minutiae, and I don't expect these things to be answered. But
there's a double taper